Hearty welcome to the 44th session in our Learn from the Legends International webinar series in neonatology, organized by National Neonatology Forum Kerala and IAP Neonatology Chapter. It's indeed an honor to have Professor Daniele Trevisanuto from the University Hospital of Padua and Director of Neonatal Transport Service, Veneto region, Italy, who will speak to us on newer applications of laryngeal mask airway in neonates. This session will be moderated by Sir Vice Admiral Sheila Mathai, Consultant Neonatologist, RR Hospital, Director General, Armed Forces, Medical Services, and Dr. C. Vinod, Rio Maternity and Children's Hospital, Madurai, Tamil Nadu, India. Once again, a warm welcome to the eminent faculty, the moderators, and the participants. Thank you very much. JNNF. Over to Dr. V.C. Manoj.
Hello, everyone. Good morning, good afternoon, good evening, depending on whichever area of the globe you are in. I have great pleasure to introduce the legend of today, Professor Daniele Trevisanuto, an original researcher in neonatology. Daniele is an associate professor at the University of Padova, Italy, president of the Veneto region Italian Society of Neonatology, and director of the East Veneto region Neonatal Transport Service. He is also the vice director of the Master on Neonatology and Intensive Neonatal Care at University of Padua. Professor Trevisanuto is a member of the ILCOR, International Liaison Committee on Restoration, Neonatal Restoration Task Force, and a member of the European Restoration Council Task Force Neonatal Restoration. His research focuses on various subjects. He has done enough research and more on various subjects: neonatal restoration, education, maternal and neonatal care in low resource countries, neonatal airway management, and neonatal transport. He is involved in many international collaborative projects and has been invited as a speaker in about 250 national and international congresses, meetings, and workshops. Since a long time, he is conducting educational and research activities in many middle and low-income countries, including Mongolia, Vietnam, Myanmar, Sudan, Mozambique, Uganda, Ethiopia, etc. And he is the co-author of about 300 peer-reviewed articles and has published chapters in neonatology books. He has co-authored also many peer-reviewed articles. He is also the co-inventor of a supraglottic airway device for drug delivery. Friends, the introduction runs to pages. I am cutting short the introduction now. Let us hear from the legend, Professor Trevisanuto, on the use of laryngeal mask airway, something we have not been utilizing it to its fullest potential. Over to Professor Daniele.
First of all, I would like to thank Dr. Manoir and the faculty for inviting me. It is important, webinar series, and so thank you for invitation. I can think to start with my presentation. I share my screen.
Yes, sir. Please go ahead.
Okay. And so again, thank you for inviting me. And the title that Dr. Manoi gave me was Laryngeal Mask, Potential Uses or Potential Application in Neonates. I have not specific conflict of interest. I am a co-inventor of the laryngeal mask airway device with drug delivery means. And it is really my only conflict of interest. I start my presentation with this slide. Here you can see Dr. Archie Brain. Dr. Archie Brain, an English anesthesiologist, is the inventor of the laryngeal mask. In this slide, you can see Dr. Archie Brain during experiment that was took at the London hospital in 1983. The experiment consisted in a positioning of the laryngeal mask in itself. He did this intervention 3 times in himself to convince the London Hospital Ethics Committee that it was an effective device for ventilating the adults. And here you can see the stupor, I would say, the reaction of the ethics committee at the London Hospital Ethics. Apart from some anecdotal aspect of the laryngeal mask, the history of laryngeal mask is full of very nice anecdotal situation. This is the first article that has been published on the laryngeal mask. It has been published in British Journal of Anesthesia in 1983. And I would like with you to read the title. The title is The Laryngeal Mask, a New Concept in Airway Management. It was not defined as a new device, as we say. And so the concept is a different thing than the device. It's more important, more in-depth concept. Since that time, there was an evolution of the LMA concept. And as you can see here, there are some models that were produced over time, and all of them were progressively improved based on the requirements of the users, in particular from anesthesiology, that gave to Archie Brain, to the producer, some ideas to improve the laryngeal mask. Why we can consider the laryngeal mask? If the laryngeal mask, we want to compare the laryngeal mask with the first competitor, that is the face mask, we have really 2 important advantages when we use the laryngeal mask. The first advantage is that laryngeal mask compared to face mask reduce or may avoid the leak around the mask. We know that when we use the face mask, there are some papers that show that we can have 70% of leak around the mask. And so the laryngeal mask can avoid this aspect. And another important advantage is that when you use the laryngeal mask, you bypass the airway block because you are directly in front of the glottis. And while this problem could be found with when you use the face mask. What are the disadvantages of the laryngeal mask compared to the face mask? But in general, we say that you have a leak pressure at 22-25 centimeters of water. That could be a low pressure for stiff lung at the beginning, at the beginning of the first breath in the delivery room. But there are some studies that show that you can achieve 37 centimeters of water. And so this could be overcome with the laryngeal mask. And another aspect that could be a disadvantage of the laryngeal mask compared to the face mask is higher invasivity. Really, it has not been demonstrated, and so we will look at some article later that confirm that the laryngeal mask was not more invasive than the face mask. If you compare the laryngeal mask with the second competitor, that is the endotracheal tube, the advantages are very important. When you use the laryngeal mask, you have a reduced invasiveness with the laryngeal mask compared to the endotracheal tube. It has been very well demonstrated this advantage in animal as well as in adult patient. And so this is an advantage for adult patient. You can imagine that is also more important for newborns. Another important aspect of the laryngeal mask, another important advantage of the laryngeal mask compared to the endotracheal tube is easier positioning. If you take 100 person your room and you ask to position in the laryngeal mask in the mannequin, 99 of them, and so 99% of your young doctors or midwife or nurses will position in the laryngeal mask at the first start. The disadvantage of the laryngeal mask compared to the tracheal tube, again, is the leak pressure at 22-25 centimeters of water, but I told you this could be overcome. And another problem that anesthesia for the anesthesiologist is very important during the operation, during surgery, you have not a complete seal as you have with endotracheal tube. However, the risk of ingesting in neonates, in particular, in neonates, for example, in delivery room, is not a problem for us. Okay, coming back to the title of my presentation, I identify 5 potential uses of the laryngeal mask in neonates. We don't cover all of them in this presentation, but we look only at some of them. The first that we look at is the congenital airway malformation. There is a long list of case reports that of patients with congenital upper airway malformation, where the healthcare provider tried to ventilate the patient with a face mask and failed, tried to intubate the patient and failed. Luckily, he had the laryngeal mask on the emergency trolley, and this patient were saved with the laryngeal mask. And so, in many situations, there are many case reports that show that the laryngeal mask was life-saving. Just this is good reason to have the laryngeal mask as a rescue device. This is one patient that were carried for our group. I was on call. This patient was born in a peripheral hospital at 60 kilometers from Padua, from my hospital. I was on call for a transport team, and the anesthesiologist at the center tried to intubate, tried to ventilate, but they failed, and opportunely they put the laryngeal mask. When I arrived at the peripheral hospital, oh wow, I was in trouble for the transplant. So I tried to ventilate with the face mask, but it was not possible because he had an important leak around the mask because due to severe micronephrosis. I tried to intubate this patient, but really this patient had a higher profound glottis, and so with every kind of blade of the laryngoscope, with every kind of the tracheal tube, also in a blind way, I was not able to intubate this patient. And finally, another important problem was that there was a severe hypoplastic, and so the blade of the laryngoscope was not positioned in the correct way. And so I decided to transfer this patient with a laryngeal mask. When we arrived at our emergency department in Padua, the endoscopist needed 45 minutes to intubate with fiber optic scope this patient. Another idea to manage the difficult airway is to use the laryngeal mask as a simple method to intubate the patient. You have positioned the laryngeal mask, you can use the laryngeal mask a via to intubate this patient, as reported by this article. When I saw this article, very interested, very enthusiastic to do it, but I tried to do it, but I failed in a few patients, and I found other articles, other colleagues that failed. If you use the laryngeal mask if you decide to use the laryngeal mask as a via to intubate, we have to use a fiber optic bronchoscope. And so you can put your tube here, and after you enter through the laryngeal mask, and you can intubate the patient under vision. What happened? Okay, this is one patient that we treated, for example, in such way. This was a patient with upper airway malformation, and we use we intubate with endoscopic guided through the IJ. It was a patient with 1.47 grams, 40,000 grams, 36 weeks with per-hour malformation. But the intubation, for example, in this case, through the laryngeal mask was very easy, very effective. Another use for the laryngeal mask in neonate is regard the neonatal station. Surely this is the most important field of application of the laryngeal mask. We know that if you, from epidemiological point of view, if you have 100 patients in the general population, 5 to 10 of them require some degree of active resuscitation, for example, stimulation at birth to breathe. And we know that 3 to 5% need positive pressure ventilation. And we know from the textbook of neonatal resuscitation that effective positive pressure ventilation is the most important intervention during neonatal resuscitation. Now the question is, when we ventilate a patient, we have 3 possible interfaces. We have the face mask, we have the tracheal tube, and you have the laryngeal mask. Okay, we start with the face mask. This is a study that conducted in a delivery room in Mozambique, in Beira, the city of Beira. And we were very interested in knowing the impact of a one-day neonatal resuscitation program course. And so we collected in the delivery room 50 resuscitation. After we organized the course, one-day course, and after we collected, after the course, 50 videos, 50 other 50 resuscitation. This is the same. Here you can see the cameras that we put on the infrawarmer, and these are the results. We used the predefined score, of course, and what we found was that we regard the face mask ventilation, the performance from 20 increased to 40% of the score. This was a significant from a statistical point of view, but of course we're not satisfied with this because we want to achieve around 80–90% of the score. And so we decide to change our strategy, and we start with a low dose high frequency training. We sent the champion, the best midwife in the delivery room 1 time per week with the mannequin, and she taught neonatal resuscitation to the nurses, to the midwife who were there. After months, we look at the impact on the real resuscitation of this approach, of this training, of this low high frequency training. And what we found after 6 months was that bag mask ventilation, the score did not decrease, but also did not increase. And so the impact was again limited. This is just to show you, this is a video after the 6 months training. You can see here that the midwife tried to do the Mr. Soppa correction, for example. No, she tried to understand, but to apply what she learned in the mannequin. But as you can see here, the quality of ventilation is insufficient, but despite we organize a long training in this midwife. This is a Cochrane review published in 2018 by Qureshi, and this review included 7 randomized control trials that included only late preterm full-term implants. If you have 100 patients in need of PPE and you start with face mask, 84% of them are effectively ventilated with a face mask. However, you have a proportion, more or less 1 every 5 patients, that need further intervention. Message number 1 on mask ventilation. Teaching effective face mask ventilation in clinical practice is difficult, and about 85% of infants needing PPV respond to mask. But we have a portion of patients who need a different solution. The different solution could be the endotracheal tube. More or less, literature say that 1% of entire population require endotracheal intubation. Is a play to teach or to learn intubation? Is a children play? I like this to study because in this study we can try to understand which is the learning curve for intubation. And so how many attempts do we have to give to our young doctors or our young colleagues to learn intubation? These are two studies conducted in anesthesiology literature, where they try to assess the appropriate level of proficiency. They defined appropriate proficiency where there was an acceptable failure rate at the first attempt of 10%. And so you have to put 9 out of 10 tube in the trachea at the first attempt. And what this study was conducted in an ideal situation, in operating room with the patient who were sedated, anesthetized, and so an adult patient, and so completely different from the new. These two studies show that to achieve an appropriate level of proficiency, you need more or less 50 attempts. This is what the literature says in adults. What is the number of attempts that we have to offer to our young doctor to achieve an appropriate level of proficiency in the neonatal resuscitation or neonatal intubation? Really, we don't know this now. We don't know which is the learning curve for intubation in newborns. However, if here we have 50 attempts, it could be a problem for us, because this is a whole study from Tina Leone, where she reported that in 1994, pediatric residents at San Diego Hospital, San Diego University, had the availability of 38, they spoke to 38 intubation attempts. Of them, only 24 were successful intubation. Only a few years later, you can see here, it was exactly 20 years ago, a pediatric attending in a pediatric resident at San Diego University had the exposure to only 12 intubation with a successful rate of 4. This is a recent study from the group of Foglia Elizabeth from Philadelphia. And you can see here that success of the first intubation was only 46%. And of course, dependent on the healthcare giver position, pediatric residents, neonatology fellow, attending neonatologist. It was an increase, of course, rate, success rate, based on the role that you have. The message number 2 is that teaching effective endotracheal intubation in clinical practice is very difficult. Experienced caregivers strongly influence the success of endotracheal intubation. And finally, is that exposure to the procedure is becoming rare for pediatric residents. So we can consider another approach. We can consider the third interface that we have available. The next question is when we can use the laryngeal mask. We face a new body of PPB, and we can decide to use the laryngeal mask as the first choice. As we can also decide to use the laryngeal mask after second choice, after the face mask ventilation failed, or if you are desperate, we can use the laryngeal mask after that both face mask as well as intubation failure. Here you can see the history. In this slide, I try to put the history of guidelines for intubation, and the laryngeal mask compared in the guidelines. Really, it's better to say in the text of the guidelines for the first time 5 years ago. What the guidelines in 2000 stated was the laryngeal mask may be an effective alternative in case of failure of face mask, ventilation, and or tracheal intubation. If you want to come back to the previous slide, the laryngeal 2000 guidelines, here we can put suggested to use the laryngeal mask in case of failure of face mask, in case of face intubation. So here we have 2 smile, but At that time, the laryngeal mask was not considered as first choice. What happened from 2000 to 2005 or later? In 2015, the laryngeal mask increased its reputation because from the text she was put in the algorithm, directly in the algorithm. Okay, so these are the American guidelines. What happened in 2015, 2020? This review, Cochrane review, I show you already it, but now we look in. This review in 7 randomized control trial, almost 800 infants were enrolled in this review. The quality of evidence was rated from very low to low quality. And what this review and meta-analysis said is that if you have a patient in need of PPV and you start with LMA compared to bag and mask ventilation, you reduce the need for intubation. And so laryngeal mask reduce, compared to face mask, the need of intubation. If you start with the laryngeal mask, you can reduce the ventilation time significantly. And so if you have a patient in need, 100 patients in need of PPV, and you start with face mask, you save or you effectively ventilate 84%. But if you start with the laryngeal mask, you effectively ventilate 97%, and so only 3% of your patients in need of PPV will need intubation. The sixth study enrolled in the Cochrane looked at a short-term outcome, or important outcome is better to say, including, for example, need for intubation, ventilation time, and so on. This is the largest study published so far on the laryngeal mask airway during attestation. This study was a collaboration among University of Bergen, Norway, Makerere University in Kampala, Uganda, our university, and Karolinska Institute in Sweden. We included in this study neonate. We estimated gestational age of at least 34 weeks, of the peer to weight of 2 kilograms. The study was conducted at Mulago Hospital in Kampala between May 8, 2018 and 2019. All resuscitation were video recorded. The study design included a by-day cluster randomization. At 8 a.m. in the morning, we opened the envelope, and if there was breathing laryngeal mask, all the patients in need of PPV for that day were ventilated with the laryngeal mask, or if there was breath and face mask, they were ventilated for the entire day for the next 24 hours with the face mask. In this study, we used a critical outcome, not important outcomes such as intubation, because in this hospital, intubation was not allowed. And so we use early neonatal death within 7 days, or admission to the NICU with moderate to severe hypoxia ischemia at 1 and 5 days during hospitalization. This is the flow chart. 563 patients were treated, were randomized to the laryngeal mask, and 591 patients were included in the analysis, that patients who were treated with the face mask. 3.5 patients who were randomized to be treated in the arm of a laryngeal mask were crossover to the face group, and so failed the laryngeal mask and were ventilated with face mask. 10.9% of patients who were randomized to be treated with face mask failed and were treated with the LMA. This difference was significant, and so more patients in the group of face mask failed compared to the group with laryngeal mask. However, if you look at the primary outcome, the composite outcome, early neonatal mortality plus severe or moderate hypoxic ischemic encephalopathy, we did not find any difference, 27%, 24%. If you look at the secondary outcome, also in this case, we didn't find differences between the two arms. In addition, we didn't find a difference with regard to adverse events or severe adverse events between the two groups. The conclusion of this study were that in neonates with asphyxia, the laryngeal mask was safe in hands of midwives, but was not superior to face mask ventilation with respect to early neonatal death and moderate to severe hypoxic ischemic encephalopathy. The laryngeal mask in 2021, and so a few months ago, appeared for the first time in the algorithm also of European guidelines. And the laryngeal mask appeared 2 times in our algorithm. The last potential use of the laryngeal mask in neonate is for administration. That is another practice that we do very frequently as neonatologists. When we had this idea at the beginning, our idea was to use a catheter and to go with the catheter beyond the LMA tip and to arrive to the vocal cords and to cross also the vocal cords. And with this idea, we treated the first 4 patients. And what we found, unfortunately, was that the oxygenation, instead to increase, decreased. And so we were very depressed from these first results, these findings. And so we decided to change our approach, because what we thought was that probably if you do this procedure in a blind way, you don't know where the tip of your catheter goes. You can go to the esophagus, it could go here, so we don't know. And so we change our approach. We decide to put the tip of the catheter behind the LMA tip, and so it is more or less at this level. And so to spread, to push the surfactant by using positive pressure ventilation to the left. With this new approach, these are the first 8 patients that we published. Patients had a birth-weight, all these patients were in the NICU. All they had a RDS, and this is the range of the birth weight, 800 grams, 2.5 kilograms. They were in the CPAP at 5 centimeters of water, and they had 50%, or the range was 40-80% oxygen. What we found with this new approach was that oxygenation significantly improved in all the treatment, and this is the mean, while this was the previous when we used the catheter beyond the tip. And so this was the first result. If you want to look at the result in terms of oxygen, the pre-treatment was, or the baseline oxygen was 55%, and after the treatment went to 30%, 3 hours after. And if you want to look at the chest ray, this was the chest ray of a patient with 33 weeks, before and after 2 hours. So as you can see here, the volume and the transparency significantly increase after the surfactant treatment with the laryngeal mask. Here we are young, and we were using the laryngeal mask. This is a particular laryngeal mask with some specific characteristic with my colleagues. What we know based on the literature on of laryngeal mask and surfactant. There are 5 observational studies. 3 of them are from our group, and what we found was that feasibility as the efficacy was high for the most part of them, and we had not complication. This meta-analysis, review and meta-analysis study, we tried to summarize the randomized control trial who consider the use of laryngeal mask for surfactant intubation. And we found 2 studies that compare LMA versus nasal CPAP, and 3 studies that compare LMA versus SUSU. In these 5 studies, 3 models of laryngeal mask were used: laryngeal mask Procil, Classic, and iGel. What we found from what this meta-analysis suggests or found, we know that if you use the laryngeal mask and we give surfactant through the laryngeal mask, compared to the CPAP without surfactant, we decrease the need for mechanical ventilation or intubation. if you compare the laryngeal mask versus insure, surfactant administered with laryngeal mask or versus insure, we found that there was a similar decrease in the need of intubation or mechanical ventilation. So surfactant administration via laryngeal mask or insure seem to give the same results. If you give surfactant via laryngeal mask compared to nasal CPAP only, we decrease the need of FiO2 at 1-6 hour. And if you use the laryngeal mask, surfactant given via laryngeal mask or surfactant given via insured approach, we have the same FiO2 at 1-6 hour. What our meta-analysis showed is that surfactant administration via subargotti airway device reduced the need for mechanical ventilation and increased the amount of required surfactant. It was a small amount of need of surfactant. Short-term oxygen requirement decreased with subargotti airway device compared to nasal CPAP alone, but are similar to insure approach. Available literature include a few small quality studies that prevents to draw strong conclusion. Our conclusion of this meta-analysis was that surfactant administration via subargotti airway device should be limited to clinical trials. And so what we know in this moment regarding the laryngeal mask surfactant administration, based on my experience or my idea, is that if you use the laryngeal mask and we use a catheter in a blind approach, and the tip that is, we try to put the tip of our catheter behind the tip of the laryngeal mask, could be a dangerous approach. If you use the catheter that is positioned behind the LMA tip, I think that's possible. We can achieve a better oxygenation of the patient, we can avoid intubation. But in my opinion, the ideal approach is to use this approach, but under vision. We want to use an endoscope to have the opportunity to pass the vocal cord under vision, and this could be the future project for laryngeal mask. We try to develop this idea. It is the laryngeal mask where you can see the catheter here that go to the vocal cord, through the vocal cord. Here you can see the camera that can help you to see where you are going. So surfactant administration via laryngeal mask, but under vision that is different. We performed animal study. We enrolled the pigs, 2 kilograms. We used the puractant alpha with technetium, and so we were able to label the surfactant, and we measured the distribution of surfactant by using gas scintigraphy. Here you can see our result that has been published 2 months ago. When you use this kind of approach, and so the laryngeal mask behind the with the tip here before the exit of the laryngeal mask, you can see that surfactant go to the lung, but a part of surfactant goes also to the stomach. Okay, this is the anterior, posterior part. These are the lung, these are the stomach. If we use our approach, laryngeal mask camera anterior and posterior region, so under vision, what we found was that the most part of the surfactant went to the lung, and just only a little part of the surfactant remain, or is better, there was a reflux from the as we do with Lee's approach, as part of surfactant remained in this part, and while, as you can see, no surfactant arrived to the stomach. This is the control group. This study, this animal were treated, 6 patients, 6 pigs were with the insure approach, and of course, all the surfactant went to the lung. And so this study showed that we have a good opportunity. The surfactant administration is very similar to the gold standard that we have now. What are the future of the subargotti device? We have at the moment 7 brands of neonatal laryngeal mask that we have summarized in this review. Only one of them is don't have a cuff, and so is a not rated cuff. What we know is that iGel, that don't use a cuff, has the lower leak around the mask compared to the other 6 laryngeal masks, and also compared to the triangular face mask, and also compared to the round face mask. This study is a study from Sydney, from the Sydney group of neonatologists, but we have to take, it is a mannequin study, and we have to take caution to the result, also because the study were conducted in a pediatric mannequin and no neonatal mannequin, and was a mannequin, so it's completely different from newborns. Why to use a non-cuffed laryngeal mask? Because you are very fast. You don't need to air in the cuff, and you can achieve effective ventilation in a very short time. However, there are other interesting laryngeal mask models. For example, this is the Supreme LMA size 1, where you can have the gastric access, and so you can use your catheter that go out from the tip, and so it is go to the stomach, and you are sure that the positioning of the laryngeal mask is correct. This kind of laryngeal mask is used mostly from anesthesiology during the anesthesia. We don't know the size of the laryngeal mask. You know that the laryngeal mask is just size 1 now available in the market. There is only one size. This is a 700 that was treated by our pediatric resident. And you can see here that there was a damage that completely solved after 1 week, but there is an enlargement of the esophagus at entry, at admission in the NICU. We don't really a lot of regarding the anatomy of the upper airway in the newborn. And so in this study, we tried to collect anatomical measure of the upper airways in cadavers of fetus. And in addition, we assess the relationship between anatomical areas and the size 1 LMA. Here are some slides of our model we try to measure. And here you can see this is the trachea that was lifted from this is the esophagus. And here you can see tip of the laryngeal, the cuff of the laryngeal mask, as you have an enlargement of the esophagus. We collected some mold, and here you can see how the laryngeal mask can work in a cadaver. Here is the iGel again. And if you look here, we try to ventilate kindly, and you can see here that you have a good expansion of the lung, and you have enlargement, or is a position in the laryngeal inlet of the laryngeal mask. We collected 16 fetus, and we try to prepare the measure, and now we are trying to prepare the laryngeal mask dedicated to preterm newborns. Surely, here you can see the relationship of the upper airways with the size 1 supreme LMA, and as you can see here, it is clearly too much big. Which were the conclusion of this study? The study reports for the first time the anatomical sizes of the upper airways, laryngeal and laryngeal areas in cadavers of fetus. This data have information for designing a suitable and a safe supraglottic airway device in preterm infants. Available LMA using neonates weighing more than 2 kilograms are potentially dangerous in smaller patients. I think it's smaller than 1 kilo. I am going to my conclusion. The use of laryngeal mask, of course, include some gaps of knowledge that we summarize in our in the European guidelines last fashion. We don't know how the laryngeal mask work in the setting of meconium stadium fluid. Despite our study conducted in Mulago in Uganda, 60% of our enrolled patients, of our 1,200 patients, had a meconium stadium amniotic fluid. And so we can say that this study showed that laryngeal could be effective also in this case. We don't know if the laryngeal mask is effective during chest compression. There is a very recent study published last month, pediatric research by the group of Satyan, that showed that they compared in lambs of, and so it's an animal study. They compare the effectiveness and the ventilation, the effectiveness of ventilation as the ROSC during chest compression with laryngeal mask and the tracheal tube. And the conclusion were that in the study, I want to underline this, was that the laryngeal mask was effective as not the tracheal tube. We don't know if the laryngeal mask is effective or useful in administration of emergency endotracheal medication, such as adrenaline. We don't know really which is the best model that we can use. Is it better to use inflatable cuff or cuffless LMA? This is a question that remains, and we don't know the size. Probably we don't know if we need, we know that size 1 is very good for patients, in my opinion, higher than 1.5 kilograms. Less than 1.5 kilograms, we need 0.5 or 0.75 size. To teach use, I think that also in our courses, the laryngeal mask is very well accepted. I saw that in every setting, low resource setting, middle resource setting, in high resource setting, always the participants were enthusiastic of the laryngeal mask because they cover a device that can save the patient without the skill of intubation. But the perception is that it is easy to teach, but not really how to teach it. Message number 3, conclusion. In clinical practice, the laryngeal mask is effective for PPV, also in inexperienced caregiver. I show you the data from Ulago Hospital. About 92-99% of late preterm neonates in PPV are effectively ventilated with LMA. There are several case reports that show that LMA was life-saving in neonates with congenital after-hour malformation, and so it is a good idea to have the laryngeal mask in our emergency room. And the LMA may be used for administration, but further study are in this moment needed. My last sentence regarding the conclusion that also Qureshi reported in its review, Cochrane review. They concluded that it is important clinical community resort to the use of LMA more proactively to provide effective ventilation when newborn is not responding to bag and mask ventilation before attempting intubation or initiating chest compression. Thank you for your attention.
Thank you so much, Professor Daniele. It was an amazing lecture of something that we don't know much about, to be frank. So
thank you.
Now, I would request all the attendees to kindly write your questions in the Q&A box, not in the chat box. And in another 2 minutes, we have a very interesting panel discussion coming up. Friends, now we have a very interesting panel discussion coming up. I have great pleasure in inviting two great neonatologists from India. Uh, we have Surgeon Vice Admiral Dr. Sheila Mathai. She is incidentally the Director General of Armed Forces Medical Service as well, but she is a core neonatologist also. Welcome, ma'am. We also have Dr. C. Vinod, the consultant neonatologist from southern India, who will be also moderating this session. Welcome, Dr. Vinod. Kindly unmute yourself, and the floor is all yours. Kindly take over the session. I would request everyone to kindly write your questions in the Q&A box, not in the chat box, so that the questions will be visible for the moderators. Thank you.
Thank you so much, Dr. Manoj, for this absolute honor that I have been given to chair this absolutely outstanding session today. Congratulations, Professor Daniele. Your talk was riveting. I don't think anybody stopped listening for a minute. And there were so many aspects which you clarified on this topic, which really is, the potential has not been tapped completely in neonatology. There is no doubt about that. And though many of us in the audience, particularly those who have been practicing neonatology exclusively, have used the LMA. I myself have had experience when I was professor of pediatrics and neonatology at the Armed Forces Medical College, but there is so much more that we need to learn. Now we have a few questions, many of them are repetitive, but before I go on to the questions, may I ask you one question, Professor Trevisanuto? You said that, you talked about the various types of LMAs, but you didn't really tell us whether or not the curved versus the straight LMA is better. Now, the classic LMA is essentially a straight tube, whereas some of the others are now curved. So would you suggest that we use the curved more than the straight, or is there no difference between the two? I think you have to unmute yourself.
Yeah. First of all, I would like to say you that I have not conflict of interest with the producer of LMA, so that is important for me. I can just tell my experience. My experience was born with the cuffed LMA, the classic LMA at the beginning, and I worked I had a lot of connection with the inventor, with Dr. Archie Brain, that is, you can imagine very, very expert, is know every small details that can help you to understand how to use. And so I learned a lot from him and from anesthesiologists, because they use more frequently than me. And so I went at the beginning in the operating room with them. And so I think that the Airgel, we have to do the names. The Airgel is the without a cuff, and so is a gel that when achieve the mucosa, it become soft, and so you do an import seal. That is the why it's called Airgel. I think that is very useful for new users, because as I told you, I show you in the video, you have to introduce it, and there are some also information how to put it, because you have to go against the palate and so on. But these are the details that I avoid to present here. When you have inflatable, you have to put there, and I saw in my experience, I saw that some young doctors or nurses, they don't know where to put the syringe, and so for an expert like me, for example, I think that, or like you, I think that the cuff is less invasive probably, and so you can use it for this.
Excuse me, Professor Daniele, I was asking about the shape, the curve.
The curve.
Yes, yes.
The curve, the shift. No, but the shift in general, the shift of the laryngeal mask are more or less the same, like a little bit curved, like a part 1 or 2 In my opinion, endotracheal tube, I prefer the curve. Sorry, I didn't understand your question well.
And the other question that I just wanted to ask you before we go on to the questions in the Q&A box is that you said that you can give the surfactant through the LMA while the baby is still on the nasal CPAP. Am I right? That the baby is on the nasal CPAP and you can give the surfactant through the LMA. So now, are we to understand that the LMA doesn't cause any obstruction to the CPAP? Because the nasal CPAP is going through the nasopharyngeal airway and the LMA is obstructing that part. So how does that work out when you're giving the surfactant?
Okay, thanks for this question. Yes, of course, when you put the laryngeal mask, you lost the advantage of the CPAP. Yes. But in that case, we put the laryngeal mask, the CPAP, the tube, we remove we leave the nasal cannula, of course, in the baby. What we use a deviation for giving the CPAP through the laryngeal mask.
Yes, that's what I wanted to ask you, that you can give the CPAP temporarily through the laryngeal mask while you're giving the surfactant. Now, if you can do that, and if you, as you said, that the leak is at 25 to 22 to 25 centimeters, why hasn't the LMA ever been used for CPAP?
The CPAP was born for anesthesia, please remember. And so the patient has to be happy to have in place the mask. And in this case, we have a more effective and more acceptable, less invasive modality to administer CPAP. There are some studies in adults. During the weaning for intubation, they use the laryngeal mask, but the patient were sedated. It's not the case for the newborns.
Yes. So we'll just go to the questions in the Q&A. There is one question from Dr. Paul. He says that, do you think that in the next NRP guidelines, the LMA will replace the face mask and other modes of giving positive pressure ventilation as the primary mode?
If you read the literature, we have a long discussion with the ILCOR task force, neonatal ILCOR task force. If you look at the literature, yes, the laryngeal mask came first because it's more effective than face mask, for example, and is not more invasive because no damage were demonstrated. But you know that the guidelines are very conservative. It's very difficult to change a established guideline. And so I don't know if they will, I think that it can replace in case of face mask failure. That is important in my opinion, because you can save a part of intubation and in non-expert. I think level 1, level 2 hospital, in that case, the laryngeal mask could be very useful. But we have to need to increase our experience with the laryngeal mask because neonatologists don't think laryngeal mask is available. It's not in their mind. It does not exist. While in the anesthesiologist, the anesthesiologist in the delivery room, he asks for the laryngeal mask. It's completely different approach.
You're so right. And there was a question from Dr. Levent who says that how long can we ventilate with an LMA? And in relation to this, there was another question that could the inflated cuff cause necrosis after some time?
How long, for example, the patient show you was the laryngeal mask stay in place for 5 hours, and so for a long time. But the patient, as I told you, has to be sedated. My opinion, in the the ideal use of the laryngeal mask is in asphyxia with patient with mild to moderate asphyxia. And so patient that my mind that we can use the laryngeal mask for a few minutes. Of course, if the patient in complete depression, you can use also for hours. But I think that that is the ideal patient. For example, a patient who the mother received opioids before the delivery, you have the patient depressed and you have to ventilate, you fail. Or in asphyxiated patient, we demonstrated that the study was conducted in Africa, they were severely asphyxiated. And so you cannot change the depth of the brain damage with the laryngeal mask or but with any kind of interface, because the damage is already down before birth. But the ventilation was really part of them effectively performed. The other question was, sorry, the time and the...
And whether or not the cough can cause necrosis. Necrosis.
Compression.
Necrosis. Oh, yes, it depends. There are some studies that show that when, in the odor study, showed when we use the milliliter of air in the cuff, really should be better to use the pressure in the cuff. In the odor study, the Archie Brain, Dr. Brain, and others show that when you go up in a pressure higher than 60 centimeters of water, you can, for a long use, during anesthesia, 2-3 hours, you can provoke necrosis, but otherwise it's not a problem for short-term uses.
So in that way, the eye gel is better for newborns? Do you think the eye gel is better?
I don't want to, I think that eye gel...
Thermoelastic,
for the beginner...
Thermoplastic elastomer. Is that better rather than a cuff?
For the beginner, I think that eye gel is easier to learn. And there is, I show you the mannequin study from Sydney. They show that is impressive. The leak is only 3%, 6% compared to 25% of face mask, and 35% of the second better laryngeal mask. But I was a reviewer of this article. I was not convinced because I don't believe to the mannequin study, but in particular in child mannequin and so neonatal mannequin. So there are no studies that have compared the laryngeal mask, the eye gel with the classic, for example, in neonates. In adults, there are many studies during anesthesia, and the effectiveness more or less is similar. And so I don't think there is a big difference apart from the learning.
So before I hand over to Dr. Vinod, there's one question on whether or not the LMA will compromise feeding. Once you're using it.
I think that you cannot use the laryngeal mask for a long time, and so I think that with the feeding is different. Yeah. So yes, it does not make sense to use the laryngeal mask for long time.
Thank you so much, Professor. I'll ask Dr. Vinod to take some of the other questions.
Yeah, thank you, madam. Before going to the questions, it was a crisp and clear, nice presentation, sir. Much informative, evidence-based as well. So we'll take few questions now. Two questions which are similar. Someone wants to know about the size based on the weight of the baby. It is 880 grams. You mentioned in a talk that 880 grams baby was used LMA. So, but 1,500 was, it was termed as a cutoff. So, is it okay to use for an 880 gram? And the same way, one other person, Goshal, has asked about the size, selecting the size regarding LMA, using LMA.
Okay, thank you again for this question. LMA, look at the it is written on the box of the LMA is approved for patients with weight higher than 2 kilograms and higher or equal 34 weeks. The same thing are written in the guidelines, American guidelines. In European guidelines, we included also 1.5 kilogram because we conducted a randomized control trial in Hanoi, in Vietnam, and we showed that laryngeal mask, in that case, we use Supreme LMA in that study, was effective also in patients higher than 1.5 kilogram. For patients with a lower bit weight, I think it can be used only from doctor with experience, because there are many small details that is better not to explain now, but okay. The second question, okay, is regarding the size. We have just size 1 for LMA. There is just one company that say that they have 0.5, But if you look at the shape and the measure of the cuff is identical to 1.0, and so is really smaller than what. And the size 1 is recommended for patients between 2 and 5 kilograms.
Yeah.
We are trying to prepare, we are working on a smaller one size because you know that preterm newborns are the goal for us at this point. Now, a good point also for surfactant administration, new laryngeal mask, but is not time now to present it. We hope to have next year, Dr. Manoi.
So
Definitely. We'll call you again to get an update on your research.
Thank you, thank you.
Yes, we are looking forward to
okay,
getting
2 questions
more
regarding
science.
surfactant administration, sir. Can surfactant be administered directly without catheters? One person has asked that question. And one another thing is, can the minimally invasive techniques be compared with the administration using LMA?
There are no study comparing Lisa or Mr. with LMA, and so I don't know. Of course, Lisa is widely used, but there are no study compared to this approach. And it can be administered directly in the catheter, in the main tube of the laryngeal mask, the surfactant. But I think that you need a catheter, the short catheter with the tip in the middle of the end, not beyond the tip, but because the most part, the risk is that you lose a lot of surfactant in that case, and so it's better to use, in my opinion, a short catheter. You don't need the Lisa catheter. You need a suction normal suction catheter. You don't need to spend money for this, and so.
Okay, sir. Thank you. So, what will be the better practice in a primary healthcare system? In a primary healthcare setting, using a CPAP or LMA ventilation, which is going to be better in a primary healthcare setting?
No, I think that I think that in the primary healthcare setting, but also in high resource, in high level care setting, I think that CPAP has to be down with the interfaces that we are already using. That means short nasal cannula, nasal mask, and not with the laryngeal mask, because again, laryngeal mask has been used in patients who are sedated or are happy to receive it, and so don't use the laryngeal mask for long period.
Okay, fine. So one another question from Dr. Manjusha. If surfactant can be administered via LMA, then why not drugs like adrenaline during resuscitation? Can it be given effectively or reliably?
Thank you, Dr. Manusha. Good question. We in recent review article from the Will group, we showed that adrenaline can be administered also through the endotracheal tube. Before we say we don't know the efficacy, while if you look at the literature, it was effective also by using a tracheal tube. There is just one study in a very small patient published in, I think, 20 years ago in pediatrics, where they used it in the 800 grams patient. They administer surfactant, they administer adrenaline via laryngeal mask, and it was effective. We use very small amount of fluid when we give adrenaline. And so I don't know how much adrenaline, if you put in the main tube of the laryngeal mask, can achieve the lung and the absorption in the lung. And so is the question. We don't know if this works. Could be reasonable. I told you that so far there is just one case reported to my knowledge.
Do you want to continue, madam? Hand over to you, madam.
Thank you. Dr. Daniel, there is one more question as to whether when you put the catheter to give surfactant, can you localize the tip of the catheter by an echo or an ultrasound? This is by Dr. Moretti. So he's asking whether the tip can be localized by some ultrasound or echo or whatever.
Thank you, Corrado, for this question. No, we don't. We decide after our initial experience on the failure of the laryngeal mask distally positioned. We decide to leave it in the main tube. It could be an idea, but the problem is that the vocal cords are not happy to be passed by a blind catheter, and so you are in the blind situation, and in that case you dangerous. And so I am very quiet to give specific. It will be a very good idea, but all the approach also in adult upper hour management is to do everything under vision. I think that the future is under vision for every kind of supraglottic airway device. Blind intubation through the supraglottic airway device at this point is not recommended, or is
There's one more question which I would like to ask you, Dr. Daniel, is that what is the role of the LMA in transport of babies? Transport from one...
the transport. This is another interesting question. I had not time to show you some of our cases who were one case from our group, and who were extubated during the ambulance transfer. It was we introduced the laryngeal mask. We arrived in our NICU without any problem. There is another study from Australia where they have where they were transferring septic babies who had important apnea during helicopter transfer. They put the laryngeal mask and the patient was effectively ventilated. I think that during the transport, in case of emergency, not as a first choice, I think that the laryngeal mask is very useful tool instead of intubating during the transfer. And so, yeah. Yes, we have the laryngeal mask in our transport bag, and so very rarely we have used it, but it could be useful to have it there.
And there's one more question that one would like to ask you, is that it seems now, and I think we will all agree, all of us who have attended, and that's almost 150 people, that we all want to rush back and see how we can use this LMA more effectively. Now, the thing is that when we use it on the mannequins, because I personally had experience, it's very easy to put. Many of these mannequins, you don't need to make any effort to put the LMA into the mannequin. And to my mind, I think it gives a false sense of security. You feel it's so easy. Do you think that we should be, teaching particularly our, younger colleagues and nurses, etc., on cadavers? I know it's not easy. But do you think that is better, more effective to learn to insert the LMA on a cadaver vis-a-vis a mannequin? The mannequin somehow or the other give a very easy feel when you put the LMA. Particularly some of just the heads, they're too simple. The LMA just goes so simply that you feel as if...
Yes, okay. I think that the learning curve has to be a training on the laryngeal mask, a training on laryngeal masks, in my opinion, has to be organized in a mannequin at the beginning, and every participant to our courses, also to your courses, say, oh, but it is so easy in the newborns. And really, the answer is yes, it is easy. In a mannequin, probably is easier than in the baby is easier than in the mannequin. However, my training course was based on the participation to two morning section in the operating room in our gynecology department, and I spent. I think I put 10 laryngeal masks in in the mothers, and I was very happy. And so I became, at the end of the day, I said, oh my God, it's easier also in the human. And so my suggestion is please spend 1-2 days in your operating room with your anesthesiologist, and you become confident with the use of laryngeal mask. But every time that I was in the delivery room, there was the opportunity to use the laryngeal mask, I asked it to the pediatric resident that has the responsibility of every procedure in our center, because we are a teaching center or a university hospital, or midwife. And when I asked, please use the laryngeal mask, they always effectively ventilated the baby. And I faced the same success in the hands of midwife in Africa. When we went there, also in Vietnam, in Hanoi, I went there. We organized a afternoon training during an afternoon, and so with the mannequin, blah, 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 blah. And after they went in the delivery room, and it is impressive, but the chest of the movements, the chest of, we saw the movement of the chest in most part of the patient. I want to say more than 90-95, and so more effective with the face mask. And so, yes, in my opinion, the learning curve is really very short, also in humans. And so, but you need to do the step. You need to do the step. The anesthesiology at the beginning had the same problem. Laryngeal mask was present in the market 30 years ago. They saw, wow, we have the face mask, we have the endotracheal tube, why we need to use another device? But now in UK, 80% of surgical intervention or anesthesiology intervention made by laryngeal mask, because it's less invasive. The day after, they have not a problem to the trachea and so on. So there are important advantages in adults, in anesthesiology medicine. And so I think that just to have to take confidence. Of course, you need someone that master you to do the step. And
I think we finished all the questions in the Q&A, and I think thank you so much, Professor Daniele. That was such an illuminating talk, and I think you really fired our enthusiasm to learn more about the LMA and to use it more in our various settings. I'm sure all of us will try, at least to the best of our ability, to increase the use of this wonderful device. Thank you so much for the
thank you.
information and sharing of knowledge.
Thank you, Professor Daniele. Really, it was a nice talk, much informative. Thank you.
Thank you, Dr. Vino.
Thank you.
So well said, Dr. Sheila Matahai, Madam. It is actually one of those talks that has actually stimulated us to do more on this topic. But this is an area where there is a lot of more research needed, and then you have been the leading light in this regard. So I would like anyway, we need to, even though it was a very nice session, we need to end it at some point. So let us I have the pleasure of and the honor to thank all three of you, Surgeon Vice Admiral Dr. Sheila Matai and Dr. Vinod, for moderating this session so very well. Thank you, Madam and Sir. And Professor Trevisanuto, I think this is one of the talks that is really going to instigate our the urge to research more, because this is one area where there is a lot of scope, as I said previously. Thank you so much. We look forward to hearing more from you on the same topic and more in the future days to come. Thank you so much, Professor.
Thank you.
Thank you.
Thank you.
Thank you.
And
Thank you.
at the end, let me thank all of you, respected attendees, for having been with us for the last 1.5 years and more. today we come to end of this session, and then we have one more session in January. That is again on that is on another area which we discussed partly, hemodynamics. Now we are going to discuss the hemodynamic concerns in the specific high-risk neonates. We will be concentrating on the HIE babies, infants or diabetic mothers, and PDA. And this lecture will be on 27th of January at 7:30 p.m. So until then, thank you so much. Again, special thanks to Professor Trevisanuto and Surgeon Vice Admiral Dr. Sheila Matai and Dr. Vinod. Thank you so much.
Thank you.
Thank you.
Thank you. Bye.
Bye.